All right, we're live.
All right, good morning. This is Senate Health and Welfare. It is April 7th, and we're continuing to take testimony on a couple of things. This morning, it's really very important for us to understand what's going on with our primary care folks across the state and some of the ongoing concerns that have been expressed to us, both I think with the goal of understanding what, if anything, can happen in the budget or within the ARPA funds that are coming to us so that we can sustain our primary care colleagues. And then the other piece of this is we are looking very soon at some possible changes or requests for information regarding affordability and accessibility to healthcare in the state. And so this would fill the testimony, some of the testimony that we need to understand our next set of goals. So I wanted to frame that for all of us, and I see people shaking their heads yes, so maybe we're not too far off target with what we need to hear. So I'm going to thank you all for being here. Greatly appreciate it. We are going to make a hard stop no later than 9:50 because we have a joint meeting with the House Human Services folks, and that'll give us a little bit of time to stretch before we move into that next meeting. So the order that's on the agenda, I don't know if you all have communicated about an order. Yeah, I see you have. So I'll turn it over to who's the person who would like to begin, or Susan, you would like to begin. So why don't I turn it over to you, and then we'll see how things go. And again, we do have some information from you on our webpage, so you can just draw us to that as you're going ahead. So Susan, thanks a lot. Go ahead.
Thank you, Madam Chair and committee members. My name is Susan Ridson of Health First Independent Practice Association. And I appreciate the opportunity that you're giving us today to talk on the topic of primary care. I think we can all agree that a strong primary care system is foundational to everything that we are looking to do in terms of increasing access, controlling costs, improving quality, and decreasing chronic care conditions, among other things. Primary care, particularly independent primary care, is stressed financially, administratively, and is subject to severe workforce shortages. The pandemic has exacerbated these problems and is hastening practice closures, unfortunately. By May of this year, we will have lost a total of 15 independent primary care practices since 2015. I'm sad to report that we will only have 26 independent primary care practices left in our network by then, and that's concerning. Many of the closures that we have seen over the years have been outside of Chittenden County and in rural areas, with relatively higher percentages of Medicaid patients. A theme amongst these closures is just insufficient payments to cover the cost of running a medical practice because costs keep going up, and administratively, and just the cost of healthcare and so forth. Continued loss of primary care, particularly the independent primary care, is a loss for all Vermonters, loss of choice in how they get their care, loss of access, likely to increase costs and perhaps decrease quality. Vermont needs a multi-pronged, multi-year approach to strengthen and expand primary care that includes increased payments, workforce recruitment and retention incentives, and just prioritization of the primary care system as we move toward value-based payments. Jessa Barnard will talk a little bit more about some specific ideas that we have. But until then, I will turn it over to Dr. Ashley Miller. Thank you.
Thanks, Susan. And thank you all for having us here today. I really appreciate you taking the time. As Susan said, my name is Dr. Ashley Miller. I'm a general pediatrician and small business owner of the South Royalton Health Center. I'm originally from Southern New Hampshire, but I moved to Vermont in 2004 and never looked back. I left a large multi-specialty practice that was affiliated with an academic medical center in 2014, where I often had never even seen the patients that I was talking to at night while I was on call or that I was providing care for in the office, even though we tried to have team-based care and make the large patient population smaller. Once I moved to this smaller practice, we call ourselves SRHC, South Royalton Health Center. It was wonderful to know all of my families quite closely, to learn their names, their children's names, what they did for work, and as the story that I'm going to share with you shows, in the middle of the night, to have a friendly face on the other side of the phone. So about a week or two ago, I was paged shortly after midnight. And on the other end of the phone was a tearful mother that I knew very well, mom of 3 kids, dad working, mom home because of the pandemic. And her 2-year-old daughter had just woken with a scream. And this scream I've heard, mom videoed it for me before. It's a terrifying scream that she lets out in the middle of her seizures. My daughter was known to have febrile seizures. This has happened before. She's had multiple ER visits, full neurologic workup. And mom was calling because she just needed to hear my voice tell her that everything was okay and that she could stay home. So about 30 minutes later, we decided that yes, this was just one of her daughter's typical febrile seizures and she would be okay to stay at home. And this saved both the cost to the family and to our medical system, that of an ER visit or an ambulance visit. We were able to follow up with mom the next morning to make sure her daughter was still doing well, answer any questions, and help connect her with her neurologist. And to me, this is what primary care really is. This is that person you know on the end of the phone at night, providing care for your family, for your children, making sure that you have all the access to the medical care you need, and someone who knows all the medical care that you're getting and can help facilitate with multi-specialists and make sure the well care is provided. So this family, like I said, had really know them well. They're one of our many families who we provide care coordination for. And that includes helping them with food deliveries from our local food shelves, diaper deliveries. We have gas cards for transportation. We attend her older son's IEP meetings. And this is all part of what we can do as a small private practice in Vermont. And we love it and they love it. So this brings us to what Susan raised as payment. So all of those things that I did in the middle of the night, all of those things we did the next day, all of the things we do to support her family and make sure her and her kids are healthy, they're not billable services. There's no payment for them, but they're super important to making sure that family is healthy and well. And many of our families are healthy and well. So we keep doing it. Payments for the services we can bill for in primary care, unfortunately, decrease every year. Just as an example, vaccines, something that we all are very aware now of how important they are at keeping our society healthy. Luckily, the state provides the actual vaccine for us, but the administrative costs, so the needles, the syringes, my nurse's time, ordering, making sure nothing's expired, all of those bits and pieces are taken up in one administrative fee. And that fee goes down every year instead of going up with the cost of the needles and the workforce cost. So that's just one piece of many things where insurances are not keeping up with the cost of primary care. In big multi-specialty practices, PEDS is known as a losing proposition. They expect us to lose money every year, and they're okay with that because they have other specialties that bring in money and can offset the cost. And they know that pediatrics is important for society. As a small private practice, I don't have that luxury. I have to make sure that we can at least break even every year and keep supporting great healthcare workers. So my nurses, making sure that they're making a livable wage, that they're paid for their education. My front desk staff, I want to hit that minimum wage goal of $15 an hour as well. But all those pieces need to come in full circle with the payment for the care that we are providing. The other thing that unfortunately has been happening lately is the fragmentation of care. So vaccines being given at pharmacies while we field the calls that night from the worried mom with the fever or the rash from the vaccine. And then we have to figure out what vaccine was given, why it was given, make sure it was on schedule, and answer all of those questions. Again, not billable services. That brings into account too the things called bundling that you're probably all aware of. So before we used to be paid for doing a blood draw to check for a lead level, and now that's considered a bundle service. Well, we don't run the lead test at our practice. So it becomes a service that we again are providing because it's best for our patients to be able to have their lead levels drawn at a year and at 2 years in our office to make sure it happens and to make sure we can follow it up, because lead is a silent killer of IQ points, unfortunately, is still an issue here in Vermont. So that next piece brings up the workforce shortage. I had a wonderful male pediatrician who are unfortunately few and far between nowadays working with me when I started in this practice. And when he started, he was here because we were considered a nonprofit part of our practice, the health hub that goes into the schools. And he thought his loans would be repaid for working for this part of our practice. And he could stay and work with us for relatively little salary. Unfortunately, it came to light that the nonprofit we're affiliated with was not one of the federally qualified nonprofits, and his loans would not be repaid for working with us. The irony is he then crossed the border to work for a large academic medical center that was considered a qualified nonprofit to get his loans repaid. So a man who had grown up in the town next door, who had come to this practice as a child himself, who was excited to attend med school and residency and come back to provide services to his community, was lost to a neighboring state for lack of funding for his loans. So this is definitely something that we can work towards in Vermont and making it more affordable for folks to stay here in primary care, both as pediatricians, family practice, internal medicine, mental health specialists, psychiatrists, counselors. These are all important parts of our workforce that directly impact my ability to provide care for our children. The last example I'll leave you with is actually, I think, quite quirky and kind of leads to our Vermont life. I had a young gentleman who was seen by his school nurse for what looked like a blister on his small finger. The nurse saw it, and because we have a great working relationship, sent me pictures of it and said, "Do we need to worry about this? The story doesn't make sense." So we had his dad bring him in, and we took a very thorough history and found out that he'd been pricked by his hedgehog spines that Saturday morning. Interesting, not sure, had to spend some time reading about hedgehogs and what their spines have. Sent him back to the school nurse, wrapped up, fine to go, while I spent my lunch hour talking to infectious disease specialists, emergency medicine doctors, and plastic surgeons to figure out if we need to worry about this rapidly spreading blister on his finger. I had my own appointment to go to that afternoon. I had gotten him an appointment about 2 hours later with the plastic surgeon, same day, which was wonderful. And as I went to my appointment, I stayed in the parking lot finishing my note so they would have access to the important information that we had found. So fast forward 2 days, and I get the letter from the specialist talking about the appointment, and there's no mention of hedgehog spines. So worried as I was, I again called up the specialist, and we had a discussion about, oh, no one mentioned the hedgehog spines, and for whatever reason, I never got your note. So back to the plastic surgeon, the young gentleman went with his dad and was put on appropriate antibiotics to assure that his finger would be okay, he wouldn't need future surgery, and that he was happy and ready to go back to school. So again, just one of the wonderful benefits that we can provide here as small practices in Vermont in primary care. Thank you for your time.
Thank you. I think now we will forever have hedgehogs in our vocabulary. Appreciate that. Do you have an order after this, Susan and Dr. Risden and Dr. Miller? Is there?
Dr. Orton will be next.
Okay, thank
Dr.
you.
Rabin.
Hi, thank you, Susan. Thank you, Senator Lyons and committee members for taking time to understand the issues currently facing primary care here in Vermont. I'm Dr. Judy Orton. I've been in solo independent pediatric practice for 32 years at my practice in Green Mountain Pediatrics in Bennington. I've always strived to use best practices with some healthy common sense in my care of kids. I love being part of these children's growth and maturity, helping their families navigate parenthood, and becoming part of their family. I'm into my second generation now, taking care of my kids' kids. There's a certain satisfaction and pride when they graduate from high school, college, take a job, celebrating the next generation when they call saying, hey, we're pregnant. Would you be the pediatrician for the new baby? After I say, hold it, you got to get the OB first. But yes, it's really an honor and a privilege. Currently, I care for around 700 children, ranging in age from the newly born to around 23 years of age. Many patients complain that I fire them, but we try to transition them to an adult provider. Our payer mix of is around 50 to 55% of Vermont Medicaid, 30 to 35% Blue Cross, 10% Cigna, and then remainder is a mix of 10 other insurances. My team and I care for a high percentage of children with learning and developmental issues, congenital or birth issues, those living in single parent homes and blended families and foster care, and families with parents struggling with employment or food insecurity, substance abuse, a myriad of other stressors complicated by COVID this past year. My entire career, I've participated in practice-based health improvement initiatives, office-based research, education of medical and PA students, as well as nursing and the scattered nurse practitioners. I've been a participant in the Blueprint for 10 years since it became available to pediatricians in Bennington. I've maintained the medical home status through the NCQA at the highest levels for the past 10 years. I've continued to participate in OneCare, though the duplication of charting in a different computer system creates some hardship. Basically, due to the time involved, I keep participating, hoping it's going to get better and that it actually will add value eventually to the families we serve. I continue in this independent practice because I passionately believe I provide individual attention, just as Ashley was stating, that is harder for families to receive at larger hospital employed practices where care may be more fragmented or you see a different provider each time. I'm also able to make practice improvement changes very quickly because it's just myself and 4 other staff members and not multiple committees that need to come together and maintain a consensus. Examples are in-office lead testing, fluoride varnish for infants and young children because of the paucity of dental providers for that young age. Developmental screening, depression screening for teens, screening for social determinants of health. That's all been instituted within a week of procuring the tools to do so. We're providing telemedicine 2 weeks after the shutdown last March, when the local hospital employed pediatric practice was not able to do that well into June. I do what the needs of my patients dictate. Many times it's not compensated, except in pride. In this past year, it's been a provision of more direct mental health counseling rather than acute illnesses. We do have a mental health person through the Blueprint, but it's only 4 hours a week. So there's a large gap. Time spent in mental and behavioral health is typically always underpaid, but is so very much needed, even more so this past year. Over the past 3 to 4 years, it's become increasingly harder to pay the bills. Payments have not kept pace with inflation and in fact have effectively decreased. Examples include the immunization administration underpayments. It's disheartening when my practice is consistently a gold winner for childhood and teen vaccination rates. We increase our influenza rates annually. This year we're at 88% and have provided flu vaccines for parents and adult family members for over 20 years. This takes a lot of hard work from my entire team, with time spent in educating families, an age where there's an increasing distrust of vaccines and vaccine refusals, but it is so very much needed. Cost of needles and syringes have quadrupled in this past year during COVID. I've had difficulty getting safety needles, so because of the OSHA regulations, I'm the only one who can administer vaccines, as I cannot put my staff at risk. Payments for office-based testing like rapid strep. I get paid less than a hospital-owned practice, but the cost of the test kit is at least the same. In addition, there's the cost of the proficiency testing and maintaining lab certification. With COVID and children not being in school, I've had to throw out a dozen tests that expired for a kit I bought in February of 2020. Normally, I would use 100 to 125 tests in a year. It's good news for the children. Obviously, they're not getting ill, but bad news for the finances. PPE costs quadrupled by June of 2020, but the promised payments to allow for the cost of PPE and the extra time involved in checking in patients to determine COVID risk have not materialized and are routinely denied by Medicaid and nearly 90% of the time by other insurers. Social determinants of health, we do that. It's vitally important. We used to be paid for the cost of screening and follow-up for those with needs. That's no longer true. My computer system allows me to be my own claims biller. In this way, I can have an additional nurse. That nurse is my care manager. Through the Blueprint, I'm only allowed 8 hours per week of care management that they pay for. On average, she spends one of those hours in a mandated meeting with the Blueprint folks, and then 2 to 3 hours each week in charting on the OneCare's Care Navigator. Her work is extremely important to our family, so I pay her for an additional 28 hours a week to do the actual care management. I wish that I could afford to pay her for another 4 hours. It makes a huge difference in improving care and in keeping medical costs down, but it's not directly paid by anyone. It helps keep patients out of the hospital, ER, urgent centers, and overall improves care. I'm frugal with what we spend money on in the practice. It needs to improve patient care or efficiency, or is a safety issue that needs to be addressed. Between my husband and I, we're housekeeping, maintenance, groundskeepers, and snow removal. It's the only way I've been able to stay in business. I used to be able to afford to pay for a physician to come into the practice so that I could take a week off. This has not been affordable for 10 years. I was forced to cut back and only work part-time due to cancer treatment in 2017. But a couple of dear friends filled in for me at a deeply discounted pay. I had hardly broken even financially when Medicaid payments decreased again, and then COVID struck this past year. The PPP loan helped keep us afloat in 2020. It's uncertain times for 2021. Payroll and bills keep getting paid first, and then I get paid. As an example, this week is a payroll week, 941's due, a propane bill due, my paycheck is on hold. I have wanted to recruit another physician for years, but with insurance payments being what they are and the higher percentage of my practice having Medicaid as the insurance, it's not been feasible. I've never put a cap on a number of patients with Medicaid, but it does create a financial hardship. I was planning on working into my late 60s, but likely will be done within the next 5 years, as will the practice I will have been built, because another physician's not going to be able to afford to come in and take the payment that I do. I sincerely hope that there's a financial commitment to primary care so that primary care will thrive, as well as options for patients to have independent practices available for their health. Thank you.
Thank you. I'm writing down all my questions, so we can probably get into a discussion after we've heard from folks. I'm thinking probably that other members of the committee are doing the same thing. Who's next? You have your order, so who's next in line?
I can speak next. Thanks.
Dr. Rabin, sorry.
That's okay. Thank you, Senator Lyons and committee members for this opportunity to present to you all again. I have been a family doctor in independent practice in Vermont for more than 20 years, currently at Richmond Family Medicine, where I am one of 3 family doctors. We also work with 3 family nurse practitioners and 3 part-time psychiatric nurse practitioners. We take care of nearly 10,000 patients and see about 1,200 to 2,000 patients per month for everything from health maintenance checkups with focus on screening, immunizations, and other prevention, to chronic disease management and acute care for injuries and illnesses. Just over a year ago, with the start of the COVID-19 pandemic, we quickly shifted our practice to incorporate care for patients with COVID symptoms, evaluating and testing patients outside in a tent at first. And when under a heavy snowfall, that tent collapsed, we switched to seeing those patients in a trailer, which remains our respiratory clinic, where to this day we can evaluate symptomatic patients, test and monitor patients who have COVID, whom we're managing as outpatients, keeping those patients out of the ER or referring them to the hospital if they need that level of care. Early on, we scrambled for PPE, which was in short supply. We continued, of course, to see some patients in person in our clinic, but shifted also to telemedicine very quickly for many visits within the early months of the pandemic, and even continuing with telemedicine to some extent now. I testified last year before this committee that our participation in OneCare helped to stabilize us financially during that time when we saw fewer patients in the transition to telemedicine, and when we saw our revenues for fee-for-service drop, even as the number of phone calls from patients increased. Additionally, we benefited from the Payment Protection Program loan and stabilization grants from the state of Vermont and the Department of Health and Human Services. This funding helped us to retain and to pay all of our employees, including those who needed to be out of work to care for children or for their own health needs during the pandemic. Fortunately, none of our employees contracted COVID, and now all of our clinic staff are vaccinated. What has become clear to me is that although we were able to stabilize and keep our staff employed and our clinic functioning to take care of our patients over the first year of the pandemic, the future of primary care in Vermont looks uncertain. I do not see that we are on a path forward to keep primary care robust and able to serve the needs of Vermonters. My concerns, as you've heard this morning from my colleagues, my concerns are to do with the overwhelming burden on primary care providers, the degree of burnout, and the difficulty of attracting and retaining good clinicians in primary care. The pandemic has highlighted this, but it was a trend that long preceded the pandemic. Unfortunately, I do not see OneCare, which was Vermont's answer to the quest for an all-payer model, as a solution to this problem. Because of the particular role of primary care, from managing prevention to being the first stop for diagnosis and treatment, to coordinating care and supporting patients as they navigate a complex medical system, there's a whole clinical team approach that's required. Much of the work for this care and coordination happens within the clinic and is behind the scenes. And as you heard from Dr. Miller, some of it happens at night after hours. In primary care, we know that every hour spent seeing patients involves at least another hour of work by that clinician, responding to messages from patients, making phone calls, looking up results, coordinating care with other doctors, with visiting nurses, with therapists, with teachers, documenting everything in the chart. I spent 15 minutes yesterday on the phone with Blue Cross Blue Shield trying to get a prior authorization for a CT scan for a patient with concerning symptoms in his lungs. Staff in my office are often on hold, even for a couple of hours, remarkably, to try to get prior authorizations for needed medications or tests. In a fee-for-service system, much of this work done by doctors, as well as the work done by other clinical staff, is unfunded by the payers. In a capitation system like OneCare, there is an attempt to pay for this work. But in fact, there's little understanding by OneCare about the care coordination we do and have always done. And there are additional administrative burdens and documentation requirements for participation that make little clinical sense and add time and cost to our clinic. Additionally, in the capitation model, where a certain number of patients are attributed to a clinic and a per member per month fee is assigned, shifts in patients from one practice to another might not be captured in those payments. And perhaps more importantly, if we add another service or another clinician after the beginning of the year, we have costs associated with those additions, but there's not a way that OneCare has come up with to increase the per member per month payment to account for the additional services. which really are services that benefit our patients. For example, we brought on a new psychiatric nurse practitioner in January to help care for our patients' growing mental health needs in the pandemic, and are hoping to hire a new family nurse practitioner to help care for new patients and to ease the workload of our current clinicians. But without a clear way to increase funding, as we increase our clinical capacity, it becomes difficult to grow to meet the needs of our patients and to be able to retain clinical staff at risk for burnout. We don't get clear accounting from OneCare about attribution of patients or how the per member per month amount is derived, or even in our monthly statements what those numbers are. Perhaps in a large hospital system with financial experts, OneCare's accounting for services makes sense. But to us, with our clinical focus, even with a very competent practice manager trying to get explanations from OneCare, the accounting remains opaque, and that troubles us. OneCare also now requires that we participate in the financial risk of the organization, and at the end of the year, we will find out if we owe money back to OneCare, if the whole clinical service area, which includes other primary care clinics, none of which we have control over, has been more expensive than they anticipated. I still love to go to work and feel that it is an extraordinary privilege to care for my patients. I like the small clinic model because we really know our patients and can be responsive to the needs of our community. I love working with my colleagues at our clinic, which feels like a sort of family. Being small, as Dr. Orton pointed out, enabled nimbleness and cohesiveness, which in our case allowed us to respond quickly, safely, and to meet the needs of our patients and our staff from the very start of the pandemic. We know that we are providing high quality and lower cost care, and that this value is important for Vermonters. But we also know that to keep going, we need a system of funding that does not add to our administrative burden, and a revenue stream that we can count on so that we can keep our doors open, and ultimately so we can attract and retain clinical staff to do this important work for our patients. Thank you.
Thank you. Everything you're saying is really resonating, and I think probably with others on the committee in addition to me, but it's certainly resonating with the issues that are so important to your patients, and appreciate that. So, Lawyer Barnard.
Yes, thank you so much. I have the unenviable position of having to follow those really compelling stories, and I won't be able to come close to telling such engaging and important stories about the central role of primary care in so many Vermonters' lives on a daily basis. So thank you to the physicians who came before me to share those stories and bring that to the committee. So I'll do the bit drier job on behalf of the Vermont Medical Society, talking about how this fits into, unfortunately, not just Vermont, but national trends, and then also some of our ideas for what could be done to strengthen primary care in Vermont, which is really where I want to focus my time. So I'll just point you to a couple of the statistics in my written testimony, that this is really consistent with what's being seen across the country because of COVID. So we know visits are down still, and telehealth and work like your committee has done to continue to reimburse for audio-only care and telehealth care has been central, has been a lifeline both for patients and practices to stay afloat and to serve the needs of Vermonters. But what we're seeing is that telehealth hasn't fully replaced the drop in in-person visits, so there's still a lower number of visits. Some of these statistics are a little bit outdated at this point, a couple months old, but I'm sure the folks on this call could confirm that that's probably still the case in their practices. We know Medicare, for example, dropped off significantly. Vermont, not surprisingly, because we have such a high Medicare percentage of coverage, saw one of the largest drops in the country of about 24% in reimbursement over 2022. And again, this is a little bit outdated now, but as of mid-2020, about 8% of physician practices nationally had closed, largely attributable to COVID, not all, and 22% in primary care. So, and it's for all the reasons that the physicians who testified this morning have pointed to, reimbursement, administrative requirements, compliance challenges. I mean, as you all know, how quickly everything was changing during the pandemic. All of the reimbursement rules for telehealth, for audio only, for testing, you know, all the billing and coding changes, all of the documentation changes, all of the needs to talk to patients over, you know, screen for testing. It just was changing daily. And so the demands on practices were extremely high. And there certainly was financial support, which we are extremely grateful for, as a number of the practices on the call mentioned, the PPP loans, funding from Medicare, funding through the Medicaid program. But much of that has come to a conclusion now. And yet the needs facing practices have not ended. And so we're here to really ask that with an unprecedented level of both FMAP money coming into the state and the American Rescue Plan funds, that there be some attention to sustaining our primary care structure in a time where we really have an opportunity to do so as a state. You know, primary care, I think for years has recognized that, you know, for example, with Medicaid, often the trade-off has been, well, do we cut reimbursement or cut services? We know it's typically an extremely limited budget, and there's not room to do more. But we do feel like with the FMAP increases the state has seen, that none of that has actually gone back into the healthcare system directly. So what are our suggestions? Our requests would be to increase the Medicaid fee schedule from 100% to 105% of Medicare. We understand that the state has really been committed to that 100% level, and we appreciate that. But the irony of that system is that that doesn't always actually mean that there are increases. It means it's the same as Medicare, but the way that that formula has actually worked in some cases, that's actually led to decreases to primary care. For example, you've heard about the reductions in the vaccine administration rates. There have been reductions, in fact, in the primary care case management fee that's come from DVHA, as well as a reduction just to the visit rate in 2020 to 2021. And so we know that that has impacted our practices. And, you know, we also understand that the state is trying to move away from fee for service, but the reality is that that's still the vast majority of what practices receive, and actually what ACO payments are built off of. So it's not, it's still an important piece to pay attention to. We would also request reopening the DVHA's healthcare provider stabilization grants. This was an extremely important program for a number of practices across the state. We appreciate all of the, you know, the millions of dollars that the legislature asked to go into the provider stabilization funds. Those ended in December 2020. And we know that also overlapped with when many practices qualified for PPP loans or CARES Act funding. So in fact, some practices did not qualify at the time, but have had ongoing expenses, increased expenses and needs since December that have not been addressed. We would like to point out that the ARPA funds do include direct funds for rural healthcare providers. I know you've received some presentations from AHS and others on those funds, but we actually don't know yet, with the lack of the guidance from federal HHS, sort of who will be eligible. Will practices in Vermont qualify as rural practices under that program? And we don't know that yet. So we're not sure if funding will be available to smaller Vermont practices or any Vermont practices under that program. One other piece, you know, there's been so much discussion about how the state can use American Rescue Plan Act funds and building our state's infrastructure, investing in the future of the state. How can we use one-time funding to really ensure a thriving Vermont in the future? And we would request that some of that be dedicated to a thriving primary care structure in the future. We think there could be one-time uses. We know that the state prefers not to have that go to ongoing costs, but to help practices meet the needs of a transforming healthcare system. You know, that takes staff, that takes time, that takes financial analysis, how to meet alternative payment models, how to understand the new payment streams, how to meet patients' needs in an innovative way. Adopt telemedicine or other practice redesign efforts. That doesn't just happen on its own. That's a huge investment of time and resources to make those transformations happen. So we would really love to see some of those funds be available for one-time sort of reinvestment and health reform needs. This committee has been well aware in the past and done a lot to help us about addressing administrative burdens, but I feel like I can't have miss the opportunity to just remind the committee of the important work you did in 2020 on Act 140, which required all health insurers to implement a gold card pilot program. That means that for providers and practices that have a high rate of your prior authorizations being approved, that you would not need to go through the prior authorization process. We in Act 140 are requiring all insurers to put a pilot program in place by 2022. There are also a number of reports coming back on how to streamline prior authorization, make it more consistent between payers. When every payer has its own prior authorization system, they all say, well, ours is evidence-based, ours is as limited as it needs to be. But when they're all different, that doesn't do much to help practices implement this on the ground. So actually, I'm excited to see there's going to be a Green Mountain Care Board report coming back to you about how to use the all-payer model to really try to achieve more alignment and more consistency between prior authorization requirements. We would also like to see all payers adopt DVHA's approach to waiving prior authorization for practices that participate in OneCare. They've really, I have to give kudos to DVHA, have done probably the most of any payer in trying to reduce prior authorization as a part of health reform. And we would really like to see that go further. And as Dr. Rabin mentioned, there have been changes in OneCare regarding the primary care program. And so we are all committed to continuing to discussing with OneCare ways to really support primary care. For example, looking at this downside risk model, expanding their comprehensive primary care program, which has really benefited some smaller practices in Vermont, but for some complicated reasons is not available in all regions of the state, and also looking at other payer-specific primary care options. So that's a really important part of the puzzle moving forward. And then the workforce issues. I know we could spend a whole hour on itself on workforce, so I won't go into the details, but just to say that we really want to see the primary care scholarship program continue to be funded, which has been included in H439, and continuing to look at loan repayment and actually residency programs in Vermont. We know that where people train, not just for medical school, but residency, keeps clinicians in the state where they've trained. So thank you so much again for your attention to this issue. I know any of the physicians are happy to answer questions. We're happy to answer questions about any of our suggestions. And thank you so much for taking some time with us this morning.
Listen, this has been so very helpful and informative. It's really critical that you've taken us down into the weeds because there's a lot of understanding that comes from that. And I greatly appreciate it. And your suggestions that you've made at the end do resonate, again, I think, with many of the goals that we've had in this committee, in particular around, we know reimbursement's an issue. There's no question about it, and how to balance that off between public and private. We know there's ongoing issues around transparency. So I won't say any more about that one, but certainly the alignment piece is important. And you've also emphasized transparency, which we have worked very hard in this committee and with our counterparts in the House to ensure that there's transparency throughout the system. I do have a question. I will get to the questions. My first question actually is for Dr. Rabin, and I'm just wondering if you have your testimony in writing that you could share with us.
Sure, I will by this afternoon.
That's awesome. Don't take time out of your clinical duties, but we'd greatly appreciate it. One of the questions that comes up whenever I hear this type of testimony is, do we value our independent primary care practices? And so it seems as if we do, then we should be listening to the recommendations that are being made, because you are boots on the ground and you understand the administrative burdens that you've talked about and the wraparound services that you're providing for your patients. that is such a large goal for us, particularly we were hoping through OneCare to expand the wraparound medical team approach, and you do that. Some of you do that independently of having other office staff. So so just all by way of saying thank you. We're hearing you. We understand, and we'll certainly we will certainly take into consideration the recommendations that you've made. They actually do not deviate from some of the recommendations that we've made in the past and will continue to advocate for. The question that I'm going to ask Jessa the question, and maybe the rest of you can weigh in on this one, with respect to the prior authorization waiver that DVHA has provided, and then your suggestion is to have that integrated in with the ACO. So can you talk about that a little bit? Because it seems to me that that does two things. One, it relieves administrative burden, but B, it might encourage some membership within the ACO itself.
Sure, happy to talk about that more. So DVHA's program is integrated with the ACO, and that it is for practices that participate in OneCare. They waive almost all, not all, but many prior authorizations. There are some they still have in place for things like fit for wheelchairs or hospital beds to make sure that it's been done correctly and safely. But for many other services, they waive the prior authorization requirement if you are in OneCare with the philosophy, I think. I mean, they could certainly explain their reasoning behind it, but that if you are taking on financial risk and taking on the responsibility for the quality outcomes, that then you've kind of taken on that role and you don't have to go through the prior authorization process. And there is in Act 140, DVHA is going to be presenting a report, more of an analysis on how that's worked. I think and it's grown over time. There were some shortcomings initially. It was much more limited, sort of which patients or practices were in or out. So I think, one of the challenges with health reform in general is if the changes don't impact enough of your patients, it's very hard to benefit from it, because you still have to live in two worlds. And in fact, if more of your patients aren't in, then it's almost harder to do this. And so I think one of the challenges is that while DVHA has this program in place, if none of the other payers do, and you're still doing different prior authorization processes for each different payer, it actually hasn't necessarily simplified your life in reality. So the request would be that over time, other payers have the same, really line up their prior authorization process if they have one, so that it's similar between the payers.
Yeah, I mean, obviously the difficulty is asking or even legislating what private insurers can and will do. So that becomes very difficult, in particular for those of us in the positions that we're in here. And I know that the chair of finance is sitting in our committee and fully understands the regulatory nuance and for our private insurers, but it's worth a conversation. It certainly is, and perhaps it sounds like something that might be helpful. So I will also wanted to ask a question. Each of you or most of you have said something about the increased mental health issues associated with COVID, and because I think I heard that from the pediatricians in the room. And so can you talk a little bit about that? And perhaps there are some recommendations that you can make to us. We're very aware of the need for additional staffing and linkages so that our kids get the help they need. Maybe you could just talk about that a bit.
I'm happy to start.
Please. Yeah. Thank you, Dr. Miller.
Yeah. So right now I would say my practice is about 50% mental health visits. So every day when I come in, half of my visits either are for mental health or end up having something to do with mental health. So the increase in anxiety, depression, isolation, self-harm, suicidal ideation since the beginning of the pandemic has been incredible. Going into pediatrics, I knew that mental health was going to be an important part of my practice. So I did seek extra help in residency, working with the child psychiatrist, learning what they do and how to do parts of their myself. And this month, my nurse practitioner and I actually spent 8 hours, 3 days over a weekend with Mass General Hospital psychopharmacology and treatment group. And it was an amazing CME, and it definitely improved our care that we could provide. But we still have problems finding psychiatrists to refer our patients to, and most importantly, counselors that they can see. So right now, these kids, this is not long-standing for a lot of children, a lot of kids and teens. This is new with the pandemic, and having a counselor that can support them through this, teach them some resiliency skills, help them look at cognitive thoughts, how do they change how they're thinking about things. This would be huge, and this would prevent a lot of problems we're seeing in the long run. We've had more inpatient hospitalizations for mental health. We've had more emergency department boardings for mental health. It's been really difficult. So the biggest ask, I guess, from me is anything that the legislature can do to help recruit these types of providers, child psychiatrists and counselors into our state would be great. We have wonderful community mental health centers, but they're sadly understaffed. The case manager that I worked with from a recent case was from the community mental health center, had absolutely no mental health training at all. She had no idea what we were talking about. She was a body that could fulfill a role and do the paperwork, but she didn't know how to advocate for our patients. And I appreciate that they were trying to fill that role any way they could, but that's not what our patients need. And a lot of them won't go to the community mental health center because they've tried before, and the turnover in counselors doesn't work for them. Just as a kid, to see somebody and pour your heart out for 9 sessions only to have that person leave as you're starting to build a therapeutic relationship really sours the counseling idea for them. We're trying to get counselors in schools, which has been really helpful through our community mental health centers. We've co-located mental health with primary care, which has also been helpful. Grants, funding, anything to keep that going, and also payment parity for mental health. I think maybe it was Judy or Hannah, I don't remember, I'm sorry, that brought up that we're doing a lot of mental health care and it's not paid the same way as, a strep throat or an ear infection. Will also be super helpful because if I can get services, I can then use some of that money to hire another counselor in my office. I love the idea of having a psychiatric nurse practitioner in the office. Those are wonderful thoughts. So any support would be fabulous. Thank you.
Wow, I think that your comments about workforce are very critical and important, and you also suggest that what we understand to be the very high turnover rate that we see in our community mental health service program. So someone comes in at a very low wage, and within a couple of years is gone, if that. So moves on to something more attractive. Oh, okay. And I know we do have some interest in promoting the workforce and support for workforce. Senator Hardy. And there you go.
Yeah, thank you, Madam Chair. Thank you, all of you, for sharing your stories, and Jessa for laying out your recommendations. That's really helpful. I'm feeling like I'm getting a little bit of mixed messages about payments, and I'm trying to sort of figure out exactly what you're asking for or what you might need, which is more important. Because on one hand, I've heard that the OneCare payments, I think Dr. Rabin, you mentioned this, that the sort of prepayment from OneCare last year was really helpful during the pandemic. On the other hand, I'm hearing that it's inflexible because if you add clinicians, they're not taken into account. On one hand, I'm hearing that it's helpful to be sort of part of the OneCare program for a variety of reasons. On the other hand, I'm hearing it's not. So, I mean, I think that's probably not surprising, but as we're really thinking about how to move forward with this model or potentially another model, what is it that you would recommend, sort of big picture? Is it helpful to be part of OneCare or not? And if it's not, what would you rather see? What would be more helpful? That's a big question, I know, but I'm trying to parse that out more.
That's the question of the day, Senator. So who would like to pick that one up? Jessa, you were the person at the end of the line, but perhaps Dr. Rabin, you would like to comment?
I think it might be helpful to, Dr. Rabin, you're on mute, but I think it'd be great to hear from her as a participating practice directly, and then maybe others would have something to add.
Yeah, I can speak briefly to that. I think, it is a complex picture. It's not all or nothing. I can't answer yes or no to your excellent question. Truly, while having fixed payments or somewhat fixed payments coming in, whether we're seeing patients or not in the office, having those payments that we can somewhat count on is very helpful. How they arrive at the number and also the strings that are attached to that funding is sort of another matter. I think it would be really helpful for us to have readily understandable accounting for the per member per month payments and also patient attribution. And then also a system by which we could add services or add clinicians, add new patients without having, those funds not actually represent the work that we're doing, taking care of patients. So those are some of the issues. And then the administrative burden, this care navigator that people speak about is this enormously complex and cumbersome system, which everybody is required to use and has very little clinical benefit. This is where we're supposed to put in data about each patient that participates in our medical clinic, who's part of OneCare.
Excuse me, what is that called? You said
Care Navigator.
Care Navigator. Okay, thank you. Sorry, go ahead.
Yeah. And it's a system that was really not designed for medical clinics. It's some other kind of software. And so we all employ people to put data into that system, and it's supposed to be a way that care is coordinated. But actually, we have other ways of coordinating care. We pick up the phone, we call the visiting nurse, we say, you're going to be seeing my patient this afternoon. I saw her yesterday in a home visit. These are the things I'd like you to check. Putting that into Care Navigator, which I'm required to do, but which the visiting nurse is also required to do, it sort of just sits there in that system. But that's what OneCare requires of us. And, it takes time for our clinical staff to sort of duplicate that documentation. We've got it documented in our medical record, and then to have to document it as well in Care Navigator, where it sits being, not used except maybe as a data collection place for OneCare's benefit. That's just an example of, sort of an annoying and expensive administrative burden imposed by OneCare. It doesn't help patients, it doesn't help us.
I'm sorry, I guess the question might be, how does that data relate to the quality metric analysis that's going on at OneCare? And does it, so yeah, it seems to me that there's a lack of transparency or a lack of educational process going on between private independent care and OneCare. And that's been I think that when we visited OneCare a couple of years ago, that was a concern that we took away from the meeting and asked to have some improvement. But as you're talking, and I'll get to you in a second. Thank you. As you're talking, though, as you've all presented, it seems to me that if OneCare would be improved so that the prospective payments and value-based payments are in place and would help. And I know that during the pandemic, the stabilization fund helped with that as well. But if it's going to continue, then somehow OneCare needs to have a direct feed from people like you, and that isn't happening right now. So I know that Green Mountain Care Board has a primary care or physician advisory committee, but I don't know what input you all give to the ACO in the process. So it sounds like there's a disconnect there. I see you shaking your head. So maybe Susan Risden, you were going to comment, but I'm wondering if that is an accurate assessment of what's happening.
Well, there is some communication with OneCare. So we do meet with them regularly, and they have asked for our input on things. They don't necessarily, institute our recommendations. So there's a limitation there. I also want to say that the OneCare model, while it was helpful to have the capitated payments during the pandemic, I just want to point out that the percentage of our healthcare spend that is actually in fixed prospective payments is less than 2%. So we're talking most likely less than 30% of a practice's patient panel is under capitated payments for those practices that are even in a capitation model, which isn't the majority. So there's limitations there as well.
So increasing patient attribution might actually help, but that's another $1,000 question, how to do it. Dr. Orton.
Yes, thank you. So you mentioned attribution. There is also the attribution so that my Medicaid and there's no way I can determine the Blue Cross Medicaid is easier. Our Medicaid patients that are listed for us in the ACO is never, ever correct. There's patients listed that have aged out, that they're 25, 28 years old that I haven't taken care of, but yet by the ACO standards, we are responsible for their care. We're boots on the ground. We know which patients are high risk. That's may differ than what ACO puts on for as a high risk patient. And there's no way that we can easily change that. We send emails, we call them, but in truth, nothing really changes. So it's frustrating. And weekly, my care manager does events because it's good mental health for about these issues. And she spends at least an hour every week of trying to assess that attribution to make sure to align it as best we can. But it's really kind of a fruitless process.
Dr. Miller, and I'm afraid that this may be close to our last question or comment. So please go ahead.
So just quickly, we joined the ACO this year, and we're very thankful we did when those payments did come in the pandemic, even though we weren't seeing patients. But I agree, I have no idea how they determined the payments we're getting. To use Care Navigator, my care coordinator is already overworked at 36 hours a week. So we have not gone into the other parts of Care Navigator that would have given us more payments for creating care plans and coordination of care. And it's also not pediatric friendly at all. The high risk problems that we're supposed to be tracking are not problems my pediatric patients have. So again, it's duplication of effort that's not beneficial to our patients or our practice. They're wonderful at trying to do educational pieces, but again, not educational about pediatric issues. So this is something that we're working on this year, hopefully as the pandemic winds down, to figure out how we can use it better and access the funds better. But it's definitely has not been clear and is not improving our patient care at this point.
Well, thank you for that comment. I think that that's pretty critical, wouldn't you think? The issue around pediatric mental health that we talked about, and probably substance use disorder, which has also exploded during the pandemic. Actually, a reduction of suicide related to those areas is one of the goals within the for the ACO. So it would seem to me that it might be important for that work, that linkage to be made. So we'll have to sort that one out. I appreciate your comments, really helpful. All right. Committee, any other questions? Ruth, did you get your question answered?
Sort of.
Yeah.
I think it's a longer conversation, and yeah, Jessa, it might be helpful for you and me to have some conversations. I'm just trying to sort this out as we move forward, and I feel like I got really good testimony from you guys, but also it was a little bit like it left me wondering what is the path forward, and yeah, but I think that's kind of, you're probably wondering the same thing.
And I would love to just add quickly, I believe you've maybe had testimony on this already, but I'm not actually sure about the implementation improvement plan for the all-payer
Yeah.
model that AHS.
Yeah, we're getting that. We're getting that tomorrow.
Great. I think that
tomorrow.
perfect. I think that's perfect timing because I
Yeah.
think these are not unique
Right.
points of feedback or concerns. And I think there's been some attention to them and hopefully some suggestions for improvement and streamlining. And so I think that will be a great follow-up to this.
That's exactly our goal. I mean, we're listening, and then we'll pick up on next steps. So thank you. And Senator Hooker, last question.
Thank you. Thank you for all of your testimony. And like Senator Hardy, I was a little confused on which way to go with the ACO, but looking forward to more conversations about that. My question, though, is just a simple one. What percentage of primary care providers belong to the ACO?
I'm not sure that's a question that the people in the room can answer, but it's a question that we are asking. And if there's someone looking in right now who has the answer to that, it would be helpful for us to know.
I mean,
How many
I can
do-
speak to the independents.
Sure.
We have a majority of our primary care practices do participate in the OneCare, and that's in terms of number of patients cared for by our primary care practices, by far a majority participating in OneCare, but not all, especially the smaller practices often do not join OneCare because they don't feel they can, frankly.
Well, and certainly a hospital affiliated primary care and pediatric care as part of that would be affiliated.
Right.
And the FQHC primary care affiliation as well. So we'll get a number. We'll try to get a number from the OneCare folks.
Thank you.
All right. This has been very, very helpful, and really appreciate the time that you each have taken to think through the issues that we're concerned about. You've made some recommendations for actionable items. We will consider those, and then also some suggestions for trying to help us understand more future goals and systemic changes, perhaps. So thank you. We are now on break. Nellie, we need to leave this YouTube and we are moving over to a meeting with the House Human Services folks. So thank you all. And you each have a link, those of you on committee.